Good evening, everybody. Um, Palliative care is a subject which I believe is extremely important. It is hardly ever taught or discussed either in our undergraduate or postgraduate curriculum, and therein lies a problem. I was exposed to palliative care during my training long ago, 40 years ago, in fact, and the subject was alien to me when I first got exposed to it in the UK. But to be honest, palliative care was at a very advanced level at that stage in the UK and to a lesser extent, I believe, in the US because of the prevailing medical legal atmosphere in the US. They were, I honestly believe, a little behind UK in as far as the palliative care is concerned. But society evolves, and you will see as we go along that some debate occurred in the UK as well about what they were doing and for palliation. And so they got into a bit of trouble as well. But having said that, their concept, the Western concept of palliative care, honestly is far ahead of what we practice here. And I believe that there's a lot to learn as far as palliative care is concerned from the West. There are many things, philosophical, spiritual, and things like that, that we claim the West should learn from us, and I agree with that. But as far as palliative care is concerned, I think we have a lot to learn from the West. So the attempt in the next few slides is to try and understand what palliation is, where one can apply it, and how is it done, ideally, if you want to look at it, and where we are in this country currently, and examine if there is something to improve, and if so, what should be done. Please note that this is a subject which is open to debate. Nobody can claim that this is the way to do it. There is more than one way of doing something correctly, and there will be a debate, and I invite all of you to give your views, and then we'll see if we can understand the subject and at the end of the day, make the patient comfortable. That is the whole idea. So there will be some areas where there will be agreements and many areas where there may be disagreements, but that's the nature of the topic. And so there's nothing wrong in having disagreements. Palliative care is basically symptom care or supportive care or comfort care. These terms are used interchangeably. The basic underlying idea is that you're not treating the disease, but you're only addressing your efforts in relieving symptoms. That is the basic underlying idea. So you're not bothered about treating the underlying disease, which may be giving the symptoms. There are many definitions for palliative care. I have taken a couple, this one and another one that comes up in the next slide. It is a longish slide. You can read through it. I won't read through it, but I'm going to highlight, as I have done there, certain basic principles that govern the philosophy behind palliative care. One of them is the medical care of a patient addressing their symptoms, and very importantly, focusing on the quality of life. Please note, it's not just the quality of life of the patient concerned. When you are in a situation where the patient cannot be treated for the underlying disease, that's when palliation comes in. The family suffers as much as the patient, right? And so in a holistic approach to palliative care, surgeons and other treating doctors must be aware of the difficulty of the family and must address as well. I must say that most of us, including me, as treating surgeons, will be looking at the disease only and focusing on that. We hardly ever have the time or the inclination to address various other aspects of the patient's life and the patient's family and caregivers. And so we end up with deficiency in our treatment. And that is, I keep telling myself when I see somebody who's ill, the end of a cancer or whatever else, old age, whatever, I keep telling myself I must now cool down and not be my usual self of treating a disease, but become more friendly, perhaps, but become more approachable and perhaps become more holistic, wide-ranging interests and addressing various other issues that the family has. I make an attempt at it. And honestly, I believe that we fail many times because we do not have the time, the training, or the inclination to approach a patient that way. So the second thing that I have, another definition, I have given you the references in the lower left corner. I can share this with you and you have these links and you can see them and learn from them more. Again, stressing on the quality of life rather than the quantity, has a holistic approach to the patient and not just a narrow disease related approach. And please note these statements here. It is not just physical symptoms, but psychological, social, and spiritual problems that people face. So what happens is that you're focused, most of the time we apply to cancer, but it's not restricted to cancer, this palliation. You're worried about the cancer and the chemotherapy of 5-year survival, there's that, blah, blah, and you're so focused on it that you really do not look at the person as a whole. And once you find that you've done whatever you can and the cancer is coming back, then you have to change gears, as it were, and look at these various other things that the patients and the family go through. And that is where your role comes in as a compassionate doctor or a surgeon. And as I keep saying, you're really not trained for it. And that's when you must learn to involve a palliative care specialist. We don't have huge palliative care teams in this country as yet, as you find in the West. But you do, if you care to look for them. You do have people who have special interests in this area. And I routinely involve their care in my patients when the time for palliation comes. Let me just look at the chat box. To cure sometimes, heal often, and comfort always. Absolutely, absolutely. That is the goal and the philosophy behind palliative care. So the main thrust is that you're always thinking about the quality of life and not the quantity of life. It really, and our chemotherapists and our other colleagues in oncology really have to look at it in a very serious way, because given that there are situations where you have the need for palliative chemotherapy and palliative radiotherapy, but the important thing is that they have a very, very limited role compared to the other supportive care that you need for palliation. So we must look at the quality of life and not the quantity of life, and the spectrum of care that you have to give. It's not that as a surgeon you have to do everything yourself. There will be a team, hopefully, that works with you. But if you don't have a team, you must build a team. And what you really do is look at all these aspects: the emotional, social, spiritual, and the physical. Generally, we are good at the physical aspects of it. I will be dilating on the physical aspects, but where we lack is the other three: the emotional, social, and spiritual. When I say spiritual, I want you to understand that I'm not talking about religion. Religion and spirituality are completely different. That's a topic for another discussion. I won't go into it now. But spirituality works at a individual level. Religion works at a societal level. Spiritually, people will start thinking, individuals start thinking about the meaning of life, what they should have done, what they can do with the time left to them, and things like that. And those kinds of things have to be discussed and encouraged, and whatever is possible must be facilitated to make the emotional health and the spiritual health of the patient better. So please note that once you reach a level of palliation, you go well beyond the physical symptoms and address these other issues as well. And as I mentioned earlier, there are certain very clear pillars that have to be followed when you're thinking about palliative care, which we do not normally focus on when we deal with individual diseases. All right. One of them, main thing, is a caregiver support. it is very well known that the family and the support system that the patient has very many issues and go through a lot of stresses. And so it's important for the treating doctor to give attention to the caregiver, the family, as well as to the patient. Communication, like everything else, is the key to every kind of care. It is important for acute disease as well, for the primary disease as well. But it is even more important when you're talking about palliation. Social support is very important for our, you see, in the West, when they talk about social support, it is, simple things like transport, getting food to the house and things like that. But a very big component of social support challenge in our country is economic support. A lot of people whom we treat with bad disease actually do not have the wherewithal, do not have the money to give the kind of support that that they have to give. And that's a huge challenge. And I have found many times that I have been unable to treat people in terms of social support in these situations. Setting goals is a corollary of communication. Now, most problems that occur in treatment, most unhappiness, perhaps even medical legal issues, come in palliative care department, palliative care situation, because we have not set goals. Setting goals necessarily involves the palliative care doctors, the team, the family, and the patient. If the patient, of course, is compos mentis, can take decisions. Without all these three people getting together and setting goals, then we end up in trouble. We end up in difficulties, which may make things very unpleasant for everybody concerned. I'll take a break here for a little while and ask comments from the students and faculty. Any comments so far?
Sir?
Yeah.
I think you're touching upon extremely important points of how to handle patients with the terminal disease. Students, I think, should learn that basically you have to, as if you are the treating surgeon, if you are the treating leader, team leader, you have to have people around you. But what happens is the oncologists, in their enthusiasm to treat the patients, and they give you statistics that there is improvement of 3 month, looking at 3 month increased survival and things, as you said, rightly said, quantity of time, quantity of life is less important compared to quality. So they will give you chemotherapeutic options which may prolong the patient's life, but it will ensure the patient stays in the hospital, and there will be a plethora of side effects which makes his quality of life very poor. So I think the important statement is, do not make the treatment more enduring than the disease itself. So that is very important. So when you are the treating surgeon, ensure that you take a balanced view and also look at, there are many families which have lost their livelihoods, their homes, and their financial resources trying to treat the patient. And once the patient dies, which unfortunately is an inevitability, then their life subsequent to the patient's death is also a total misery, which should not happen. So that is what you have to guard against.
Any other comments, students, registrars?
Yes, sir. Sir, are we also talking about palliative versus hospice, sir?
I will touch on that in a minute.
Okay, sir.
I'll tell you what the difference. There is a slight difference,
okay,
but you will see it in the subsequent slides. Abdul asks, is there a limit for palliative chemotherapy? No limit. This is where the problem is. I'll touch on that also. You will find that there is a little bit of gray area about when you decide that treatment is futile. It's called futile care. At what point does it occur is something which is a little gray, and that's where all the confusion occurs. But I'll touch upon that as we go along. See, why we, go on.
There is a joke that there was a patient who was buried in the cemetery, and a medical oncologist goes with this drip stand and everything, and then opens the coffin and finds that the coffin is empty and there is a note saying gone to dialysis. So the problem is, I think you should avoid these kind of scenarios, though it is said in jest.
Yeah.
I did encounter in when I was in Christie's in Manchester, there was a extremely aggressive medical oncologist who would treat ovarian cancers even when patients were gasping for breath.
Yeah.
So I think you need to be, as a treating surgeon should take responsibility, and without offending or hurting the sentiments. I don't think they are trying to do anything illegal, but it is their enthusiasm. You need to sort of temper the enthusiasm, and especially in foreign countries where insurance is an issue, insurance is not an issue. Finances are not such a problem, but in our country it is.
Yeah.
So you as a treating surgeon has to take the lead in these kind of things.
Yeah. Yeah. So please note that while we go on, anybody else? Yeah.
Sir, Ramakrishna. Sir, this economics you were talking. So usually the palliative care should be given free. That is ideal, which is not possible many times. But Kerala has got very strong network of palliative care centers.
Right.
Most of them, they are nurses, even volunteers are also, they are taken. It may not be medical persons also. Some doctors
Right.
are there, nurses are there, even social workers, even teachers. Everyone, they come and they just serve there.
Yeah.
There is a palliative care center. They just serve there free for them, and everything is free, including medicines.
Fantastic idea.
That is there, and hospice is a concept where everything you put that physical, spiritual, social, all those things put together, they give care for this palliative care. That we call hospice. One center is there in Bangalore, that is Karunashraya. One more is in
Baptist,
somewhere near that.
Baptist has a center as well, sir. Baptist Hospital in Bangalore has a center.
Yeah, Shumaga also there is a center. It was started by one actually.
I think you muted yourself.
Her husband died, and after that she created this. And my wife, she went for this palliative care training in Kerala.
Very nice.
We have been running this for past almost 15-20 years.
Fantastic.
We have got license for this morphine also. I think we will be telling about that in future slides.
Yeah.
I will talk on that. And that basic concept is put days into their life, not life into their days.
Correct.
Sorry. It is
the other way. It's the other way.
Life into the days, not days into their life.
Days into their life. Correct.
That is the standard. This one they always tell.
Quite right.
That's nice.
While we
Kidwai also has a hospice, I think.
Palliative care center is there. So hospice is a little different.
I think palliative center is there. I think
palliative care center is there, managed by anesthesia department.
So when we talk about palliation, somehow the word that comes to our mind is cancer and nothing else. That's not true. People with advanced heart disease, where you're not thinking of a transplant, advanced lung disease, COPD and things like that, oxygen dependent, and you can't treat them any further other than a lung transplant, which is not very easy. Or crippling pain, as in very severe rheumatoid and other kinds of arthritis, even dementia. Right, where they're very, very uncomfortable, very aggressive, for example, cannot be treated with medication. I mean, medication has failed. All these are cases where you would consider palliative treatment. And this is an important slide for me because you start treatment, with a primary team. It's called a primary team, but I've made it very small here because the primacy of the primary team goes down once the decision for palliation is made. That is something the primary doctor must understand. No, Ravi made the very valid point that the primary doctor takes responsibility for the palliative care. That is true. But the responsibility there lies in referring and coordinating the work of a palliative team or a palliative doctor who usually is backed by a multidisciplinary team. It's never done by one person. And as Dr. Ramakrishna was saying, the team has many kinds of people with different kinds of expertise. And that expertise is extremely important in providing good palliative care. It may be a doctor, a nurse, a pharmacist, a physiotherapist, a psychologist, a social worker, and even the clergy. When I say clergy, it doesn't necessarily mean a Christian pastor. It could be a priest, it could be an imam, or somebody who has come from a religious background. It could be a social worker or even an ordinary person who is spiritually inclined, who can come and give his services to comfort the patient. And this is something that we have to have in mind. Okay. And so what happens is, I will go back one slide and say that at some stage, what that stage is, I will discuss again. And as I mentioned, there is a gray area. At some stage, you stop being even though you are the person treating the primary disease, you stop taking primacy or the greatest importance in patient care and gracefully give that care to the palliative care person, who along with his team will do the required job. Now, what are the kinds of settings that you have? One of the commonest things for palliation is home care. I would personally, everybody else would, I think, like to be cared for in your last days in comfort, in a place which is very familiar to you, which is your home. And so it can be a home care, or it could be that if you're mobile enough to come and get treatment, come out and take an outpatient care supplement for the continuing home care. Or if it is impossible for you to be mobile or to be looked after at home, you get yourself transferred to a hospice, not a hospital. Remember that. A hospital is an acute care setting. A hospice is different, and I'll talk a little bit about it as we go along. So you get into a hospice for the kind of palliative care that you need. And there are also many kinds of variations in this care. One of them is routine home care, where a set of instructions is given by the doctors and the nurses as to what is to be done at home. If necessary, they will visit your house from time to time. It's called, palliative care given at home, domestic palliative care. They come and give you advice and go. And when the family or the caregivers cannot look after them, you may have a 24/7 nurse or a palliative care person looking after them. That's called continuous home care. Hospice care is where you are in the hospice, so the home is not involved at all. But this hospice care need not be a permanent hospice care. Suppose you have enough backup at home where you're looked after, but your caregivers need a break. Okay, they may take a 5-day, 1 week, 10-day holiday somewhere, because they need a little break as well from the stresses of looking after the patient who needs the palliative care. And that's called respite care. So what happens is that the patient for a week or 10 days gets into the hospice, the caregivers take a little break, and when they get back from the break, the person gets transferred back to the home from the hospice. And these are the kinds of settings where you can have it. And the concept of hospice, the name Cecily Saunders, Dame, she was honored by the Queen for her great work. I think you should read about this lady. I won't dilate on this, but there's a lot of very nice write-up about this lady in Wikipedia. I would recommend that you read it. Okay, Cecily Saunders, and she is the main person who brought in the concept of hospice care in the 60s in the UK. All right, and her center, I think it's called the Christie's in southern London, was one of the first hospice to be started in the world. And she had this great thought that you matter, the patient matters because of who you are. You matter to the last moment of your life, and we will do all we can, not only to help you die peacefully, but also live until you die. No, that is the philosophy that Ramakrishna mentioned, that you put life into your days. Be as comfortable emotionally and physically as can be possible, and that is the purpose of every single hospice. So I've been to a hospice in the UK. I've not been to Karunashaya, but I'm told it is comparable and it is very good, which is in Bangalore. It doesn't look like a hospital. If you go there, you will see that there are very nice common areas where people can get together. There's some light music playing, music of your choice in your room. You don't have drips and monitors and this and that. You have people, friendly people, friends, relatives, hospital personnel, nurses, everybody. You don't have this concept of somebody coming and doing, they do rounds, but it doesn't look like rounds. You just go there and they just talk to you as a person, look at your symptoms and give you symptomatic relief. It is a new experience to get into a hospice and see, very different from what we normally have in an acute care hospital. Now, how is it possible? It accepts death as a part of life. And remember that this is the biggest challenge that we face in this country. Somehow, most of our patients never ever seem to accept death. But once the patient, the family, and the doctors accept death, it's difficult for it to happen. But if it happens, actually life becomes more comfortable. And the philosophy of every intervention, I'm not saying only medication. Remember, every intervention, it could be physiotherapy, it could be psychotherapy, it could be medication also. It is neither to hasten death nor to prolong life. Because in that situation, which is painful, which can be very, you can have great difficulty breathing and great difficulty with focusing on things and a lot of difficulty in that time. It's prolonging life actually is prolonging misery, and you do not want to do that. And focus on dignity in dying. If you accept death as a part of life, there should be dignity. In life, we have dignity. We respect people. When we tell you to examine people, we tell them, they allow you they tell you stories which they would never tell anybody else as a doctor. So they're opening out to you. They allow you to examine you in very private areas, which would never happen otherwise. So we are always innately, we have a lot of dignity in that, even though we do those examinations. Our approach is one of pure professionalism. We have dignity, and the moment the patient comes out of that couch, you forget that you've done an internal examination or whatever, and that's a person, and we give that dignity. That same level of dignity and respect must occur, even in the end stages, when there may be no control on the sphincters and vomiting, and a lot of other things which may be very unpleasant otherwise. So the focus is on dignity. As you said, we have said enough about holistic support. And the important thing is that whenever we do anything, include the family in the decision making. Now, this is not so much of a challenge nowadays because the paternalistic attitude of surgeons has gone now, for the last 30 years, from the time I practiced actually, when I looked at my bosses, even in the UK, they would just say what needs to be done, and the patient without questioning would go through it. But from the time I started practice 35, 36 years ago, that had changed already, and we would take the patient's inputs before treating. And that is even more important, not only the patient, but the family's decision as well. Even more important when you institute palliative care. Yeah. Ramakrishna mentions, bereavement support is also a part of palliative care. Very right. And I'm going to touch on that as we go along. It's important, I can mention it now, and you have it on subsequent slides as well. Palliative care doesn't stop with the death of the patient, because you have a right, you have a duty, not right, a duty to look at so many other arrangements, social support for funerals, emotional support for bereavement, care for the family and caregivers. That is also a part of palliative care. Now, somebody asked me about hospice and palliation. This is the subtle difference. Some people use the term interchangeably, but there's a subtle difference. What is this difference? Hospice care is essentially only for the end of life care. What is end of life? It's a gray area. But generally, if the life is considered to be not more than 6 or 12 months, and that is something which is important, impossible for anybody to say with certainty. But generally, if you think the patient, riddled with metastasis, for example, highly dependent COPD on oxygen with pneumonia and things like this, if you think the patient will not last another year or more, then hospice care can kick in. But palliative care can kick in anytime. There may be a concurrent treatment of the primary disease. You understand? Symptomatic as well as active treatment. Whereas in hospice care, it is only symptomatic treatment. And so once you say that there can be active treatment, the primacy of symptomatic treatment given by the palliative care team goes, because a chemotherapist or even a surgeon who is doing a palliative surgery would also be involved in palliative care. So palliative care is a broad-based term and hospice care is a little more narrow. That is the difference between the two. All right. Now we talk about symptomatic care. I will give you a series of slides. I don't want to read through these, but you will find that there are any number of symptoms that a patient who is undergoing palliative treatment will have. It can be related to various systems. In terms of eating and drinking, it's about dehydration, loss of appetite, mouth sores, dryness, nausea and vomiting, a whole lot of things along with, associated with eating and drinking. But the primary thing in palliation is pain. We have to make sure that the patient is pain-free. That is the primary responsibility of a palliative care doctor or a palliative care team. And this is the classical step ladder pattern of analgesic administration. In palliation, the concept of addiction is out of the window. When you take potentially addictive drugs for the kicks that it gives, for the euphoria that it gives, and not for pain, addiction occurs. But when you take medication, narcotic medication for pain, addiction does not occur. What occurs is tachyphylaxis. What it means is that the same dose of the narcotic medication does not give you the same degree of relief. Whereas you may end up giving more and more dosage of the medication, but that is not addiction. Please remember that. So what is the correct dose of palliative painkiller? Until the pain goes. Whatever it takes, you have to do that. This is something that very many doctors do not realize. So in the step ladder, what you start with is a non-opioid analgesic like NSAIDs and things like that. You start with that, then go on to weak opioids like tramadol, then go one step higher when that doesn't work with methadone and transdermal patch of fentanyl and things like that. And the final step is even invasive treatment like nerve blocks, epidurals, patient-controlled analgesia, neurolytic blocks, frontal lobotomy, many other things can be done, but they're all not commonly done. And so it can be anything, but the point is that you are trying to relieve pain. And this is the classic step ladder pattern. Coming back to the other proteon symptoms that I mentioned about, you can have constipation, diarrhea. Incontinence is a very big issue, particularly an emotional issue for people who will find this very crippling because of embarrassment. And enough social and emotional support has to be given apart from the nursing care that is related. Blood-related problems like anemia and neutropenia, okay? Infections in people with cancer. What do you do? We will again discuss what can be done, and that's if you have an infection in these people on palliative care. Cognitive problems, confusion and delirium is very common, and that can be extremely disturbing to the family. They really feel distraught when their near and dear ones have these confusion episodes. Emotional and mental health has to be addressed. Depression is very, very common. And medication for depression is known to help a lot of people. A lot of good evidence that if you give antidepressants to these people, they improve very well. Sense of well-being can be improved by giving steroids, for example. It may be temporary, it may be short-lived, but it gives them a good sense of well-being. Ramakrishna makes a point, another reason for no addiction is the use of oral narcotics and not parental narcotics. Yeah, fair enough. You give oral narcotics, it's less likely to be addictive. Yeah. And fertility and sexual problems, some of the younger people, very, over 70s may not present with so much, and even if they present it, they may not vocalize it. But some of the younger people with cancers can have these fertility and sexual concerns, and they have to be addressed as well. Hair and skin, hair loss, as you know, is a huge issue with chemotherapy and skin rash, hot flushes, skin color changes. The skin darkens on people with chemotherapy, and that can be very distressing to some people. Pressure sores if they are bedbound. So you can see that even though we talk about symptomatic care, there are so many symptoms and so many things that have to be addressed that it really needs a person other than a surgeon like me and you to address it. And that is something that we must understand. We should not be dismissive about it and involve a palliative care person. All right. I'll take a break and then ask for comments. Ramakrishna, you obviously are very experienced in this. Please give your inputs. Ramakrishna, are you there? Yeah, we seem to be missing him. Maybe there's a connection problem. I think he has left. Ravi, you have any comments?
Sir, as a group of our class,
Yeah,
we were thinking of opening a hospice. I don't, but I think we found there are extreme degree of regulations and red tape and things like that. Do you have any ideas how easy or how difficult it is to do it, sir?
honestly, I don't know the administrative aspects. I'll have to look into it.
But it is apparently very, I think a lot of registration and a lot of this one has to be done.
I see.
I think there is a lot of.
If Ramakrishna is available, he may be able to help us because he's been running a hospice for 15 years, he says. So, Ramakrishna, are you there? Yeah, he might have.
Hello.
You're there, Ramakrishna. Were you able to hear us?
Hello.
Yeah, go on. We can hear you, Ramakrishna. Tell me.
Sir, there is some connection problem with me.
Yeah,
Sir,
yeah.
I didn't hear what was the.
See, there are two things. I'll give the second question first. Coming from Ravi, is there a lot of red tapeism and restrictions in wanting to start a hospice?
Sir, I'm 1 second, sir. One second.
We can hear you. Yeah.
You can, sir. I didn't hear, sir. There was some problem.
The question is there a lot of restrictions or administrative roadblocks for starting a hospice?
A hospice, I don't know, sir. No, it should not be, sir. Only problem is to get the morphine. Morphine, we need RMI status. That is the recognition given by the state drug controller.
Yeah.
From there, we have to take the permission. Initially, it was with the excise department.
Right.
For past 6 or 7 years, it has gone to drug controller.
Okay.
From there, we have to take the permission, and with that letter, we have to send each time whenever we are getting the morphine tablets.
Right.
That is one. The other things in hospice, because this mainly service oriented, main problem is money.
Right.
So from government, there is no restriction. We
Right.
can do that, but we need lot of volunteers and lot of money, because most of these services are given free. In Shumaga, they have got a van, like one Maruti Omni, they have converted into van.
Right.
And if we give address of patient, they will go there and do whatever the services the patient needs. Sometimes it may be dressing, sometimes injection, sometimes any other thing, whatever they ask. But these things are done free, so they need lot of money. That mobilizing the money will be the main block.
Yeah.
From the government side, it is only for the getting the morphine tablets.
Right.
So we need that license. License means it is recognized medical institution. That is the status they give. That should be got from the state drug controller.
Yeah.
And it has to be renewed every 3 years. Once they give license, it is for 3 years.
Right.
Every time we have to keep on renewing. That is little bit headache for us.
Yeah.
But we can manage, because once you get that, you have to maintain lot of registers. The day balance, how much you have given, and you have to take the address, Aadhaar card of those patients to see that these narcotics are not misutilized.
Okay.
That's the main motto there.
Okay, so that answers your question, Ravi. It may not be
Yeah.
very difficult. I also know of individual people who are registered as palliative care specialists, and their prescription for morphine is also honored.
Yeah. Yeah.
Their prescription is also honored. Okay, so I must talk about a so-called Liverpool care pathway, which sort of ruled the roost for about 25 years. Okay, it started in the 90s, early 90s, and it unfortunately fell by the wayside in 2014 because of certain big negative campaign about it in the papers in the UK. Now they had a very simple kind of simplistic approach, and I thought a very useful approach, where they would have a checklist and they addressed pain, agitation, respiratory tract secretions, nausea and vomiting, and dyspnea as the main goals of palliation. And you will find that most people in that stage where the primary disease is not treated anymore will have these as the main symptoms. Even though I gave you a list of protean symptoms, these are the main ones, and their whole idea was to palliate those. And they said that once somebody has reached that stage of difficulty, there should be no artificial nutrition, which means that you offer them food as they want it. They have loss of appetite, they may be dyspneic, they may be disinterested. If that happens, you do not put a tube down and feed them. No tube feeding, no parenteral feeding, no jejunostomy. But they did accept that a dry mouth and in that stage, dehydration, dry tongue is extremely uncomfortable. And so they would provide intravenous fluids. Artificial hydration was very much a part of that care. But what happened was that this idea of not giving food was considered as starvation by many people. All right. And they also believed in sedation. You know, if you remember that, agitation was one of the symptoms, and they would sedate the patients because of that. And that was misinterpreted as deep sedation causing euthanasia. Remember, palliation by definition is neither prolonging life nor is it shortening life. But this business of sedation that is given either in the form of a strong painkiller or in the form of sedatives for agitation was interpreted as, a kind of euthanasia. And what happened was that I believe in certain centers, not everybody, these things did happen that way because of the wrong interpretation of the Liverpool protocol. And the other problem with it, there was a Dame Newberger report in 2014, which actually said that this Liverpool pathway must be given up. And in that report, they mentioned, that there wasn't enough individualization. The pathway came, people would tick those boxes and ended up perhaps giving extra sedation or starving somebody who would be ready to eat and things like that. And so, because this word euthanasia came in the popular papers, the whole protocol fell by the wayside. But it had many, many good points, and that is the kind of thing that I was used to when I worked in the UK. And so I think the Liverpool pathway had an unfair demise. It should have continued. Perhaps they should have modified it a little bit. Perhaps they should have individualized it a little bit. But unfortunately, that fell by the wayside. So in the present state of affairs, everywhere in the world, again, I'm generalizing, what are the things that you would do when somebody goes in for palliation? Okay, remember, I'm not talking about hospice. I'm talking about a palliation where even a specific treatment for their underlying disease can be given. Okay, but it is an incurable disease. It may not be end-of-life situation, but the disease is incurable. That's what we decided. Okay, that is palliation. There is no question of ventilation. There is no dialysis. That brings into picture the incident said as a joke by Ravi, gone for dialysis. There is no inotropic support. What do you do with antibiotics? There is somebody with metastatic disease, neutropenic, and gets a pneumonia, very breathless with you. What do you do? the difficult situation. Should you let him die of pneumonia? Because otherwise you get him out of pneumonia with these high-end antibiotics, and he's going to again suffer from the neutropenia and the breathlessness of lung fibrosis and disseminated disease. What do you do with it? Question mark, no absolute answers. What about nutritional support? Okay, should you give them, without nutrition, they cannot fight infection. So would you give them nutritional support? Most people would say no, but that's again a question mark. Hydration, you definitely give, and definitely no resuscitation or defibrillation. In fact, when you come to this stage, if somebody has an indwelling defibrillator, you deactivate it once you decide that there is going to be palliation. All right. So let me stop here again and then invite comments for these interventions or the lack of those. Comments from the audience, please. Why don't the students speak? Pawan, what do you think? Our students must talk, I hope you had read up about it before you came. Pawan, are you there?
Sir.
Yeah. What are your comments about this? Is this, do you think, correct or is it not correct?
Correct only, sir.
Yeah. What do you think about antibiotics and nutritional support? Where I put question marks.
Sir, that what you said, no, sir, it is controversial because patient
What
is
would you
already
do?
having.
What would you do?
Sir, I will treat the patient, sir. Keeping
You'll give the antibiotics, you'll give the nutritional support.
Yes, sir.
All right, Nikita, what would you do?
Sir, I'm actually a little confused, sir. Here,
right.
I think I'll draw a line in the nutritional support, sir.
Okay.
I would give orally proper nutrition, but avoid TPN or any other kind of IV extra nutrition.
Yeah. No, I'm talking about, you'd obviously offer them food. Okay. I mean, you're not going to deny anybody food. But if they don't eat, the patient has pneumonia, patient with metastatic disease has pneumonia, you have decided you will give antibiotics. Okay. And then antibiotics don't work very well if the patient does not have good nutrition. So what would you do? Would you give them a tube feeding or would you just offer them food and leave it at that?
I would give a tube feeding, sir, but not vigorously.
All right. Can anybody else have any other? I've been talking about a holistic approach. So based on that, what should the doctor do? Sanya, you want to come in? What would you do? Hello, are you there, Sanya?
Yes, sir, my network is not really good. Can you hear me?
All right, you're outside somewhere. Okay, we'll leave that. Abdul?
Sir, peg feed, sir.
You do a
Better
peg
care.
feed? Man, egg is invasive here. I'm talking about even tube feeding, I mean, nasogastric tube feeding. You know what I would do?
Sir,
Yes, sir.
I have one point, sir.
Yeah.
You ask the patient or take
Thank
his...
you. Thank you.
Sorry.
That's all I wanted.
Yeah.
You know what I would do? I would ask the patient and ask the family. This is a situation where you have to take the patient's views largely into consideration. Whenever there is a question mark, both for antibiotics and nutritional support, ask the patient, ask the family and say, look, what do you think we should do? Okay, and then take a decision. It is not a unilateral decision from the doctor. Ravi, you have something to say?
Yes. Sir, I think there is a lot of ethical considerations that come here. And there are, without naming institutions, there are institutions which would put these patients in ICU, ventilation, all these things. So I think how you pitch it to the patients and the relatives is extremely important. You have to look at it from the patient's point of view, and possibly in this case, what you would do, as I call as, for example, the projection of care. That is, to try and imagine that the patient to be your father or your relative of the appropriate age and appropriate sex, and then think what would you do if it was them. And try and I think what happens is many times patients listen to what you say because either they are anxious or they're less knowledgeable about these things and they don't know. So it is up to you to, guide them in the right way. I think you're absolutely right to take patient and their relatives, if the patient is not compos mentis, into consideration, and their views have to be implemented. But I think how you pitch it to them is very important. For example, one of my friend's mother, who was demented and could not recognize him for the last 6-7 years, would get admitted into a hospital every winter with pneumonia and go into the ICU and ventilator. This time he asked me, I told him, I think you should take your mother to the hospital, put her in the ward, if at all you want to give antibiotics, that is your choice. But I would strongly recommend you not to going into ICU and things. And fortunately, she passed away peacefully in the hospital. So I think that is the kind of advice you need to give to the people.
Okay, my experience, I'll touch on that in subsequent slides, but my experience in India, as a contrast to the West, is that the majority do not take your advice about lack of ventilation and lack of support. They do not understand futile care as a concept, and I'll touch on it in subsequent slides. So what we should understand is that there may be many pathways, there may be many recommendations and guidelines, but they're not universally applicable because, as Ravi rightly said, there are a lot of emotional and cultural issues which come into play. And as you know, ethics is a nebulous creature. It is a variable creature. And different societies, different ethnic groups will follow different ethical principles, and so you have to tailor it to your society and your cultural milieu. Now, if you look at evidence as evidence, there isn't very strong evidence for a good or a bad pathway. The imminence of death, that is the end of life care, is not really very reliable. We are not good at deciding how long a particular person in a given stage of the disease will live. You may talk about a 5-year or a 2-year or a 6-month survival rate, but that is a generalization. For an individual concern, no doctor can say with any degree of reliability as to how long one patient would live. And there is no clear evidence about hydration and nutritional support, either for its good or bad. Please remember that all these interventions can be bad also. You talk about tube feeding, the patient may aspirate and die very soon because of their sedation or whatever. So for every good that an intervention does, there may be potential bads, and you have to weigh one against the other in the light of the cultural milieu and the emotional status of the patient and the family. But there is one thing that really has good effect, and that is evidence about benefits of sedation. When somebody is in pain and is agitated, do not hesitate to give them strong painkillers, which act both as sedatives and as painkillers. Only sedation in the presence of pain is bad. It must be a strong analgesic as well. Okay, so there's one comment here: if purpose is to prolong life, no. If it relieves symptoms, yes. So that is the basic principle. That's right. So the problem that occurs is that suppose you say there should be no ventilation, but the family says there must be ventilation. Whatever happens, 1% chance there, please do it, sir. You may try to persuade them not to do that, but if they insist that you should do it, you have to do it, both for emotional and medical legal purposes. Okay. Now, if you look at advance directives and living will, these are documents that come into effect when the important principle that we enunciated in the last 2 minutes is considered. What did we say? Listen to the patient and the family. That is paramount, very important. Now, you can listen to the patient if he is conscious, oriented, and compos mentis and can communicate to you. Many times in these situations, patient will not be in a position to communicate. So when the patient is well, when there is no disease, in fact, or early disease, every patient must be encouraged to give an advance directive. Okay, an advance directive is a broad term. A living will is a lot more narrow. A living will specifies, I don't want ventilation. I don't want antibiotics when I am ill. I do not want chemotherapy once I have metastasis. Things like that. The patient has a right to decide what he wants and what he doesn't want. I have written my advance directive already. All right. So an advance directive is a broad term which involves many documents. It involves a living will, which, as I told you, is a narrow instruction about specific medical care. It can also be a medical power of attorney, which means that if there are issues, for example, I have written that if there are issues that I have not addressed, I may not be able to address everything in an advance directive, all the possible situations. So if there is something that is not addressed, then I would like my wife to be the person who takes a decision. And if my wife predeceases me, I would like my daughter to take the decision. So it's a power of attorney that I have given in my will. Okay, I may also specify whether I want to donate my organs. And I may also specify a physician order for end of life situation. Okay, so what is it that I want done and not done? So these are the things which you specify in an advance directive. And in short, living wills are a kind of advance directive. But advance directives are not living wills. It's beyond that. It is much more broader in its what do you say, in its umbrella, in its, in what it covers. So that is an important thing. Yeah. So this is another pictorial thing I took from the net. When combined, a living will and a medical power of attorney can become an advanced directive. And also, even though they are not strictly advanced directives, a DNR order, a physician order for life-sustaining treatment, POLST, or organ donation instructions also can be called an advance directive. And I would say that every person must write an advance directive. This is something that is not common in India. I may be going about 10 minutes beyond 1 hour. I hope it's okay with all of you, because this is an important topic and we've had good discussion also. So this is the advance directive. And one of the big problems is, very commonly it happens in my house also. When I talk about death or something like that, they say, no, don't say such apashakuna, that's such unpleasant thing. Don't talk like that. It is one of the biggest problems in this country. Death is a part of life. You have to face it head on. And you should not take it as a bad omen to talk about death. And you must prepare yourself and your family for death. It's an extremely important thing. And so it's important that we talk about death, we talk about a will. We never talk about a will. And then when somebody dies, there's chaos in the family afterwards about so many things, about what needs to be done for the obsequies and what should be done with the property, with everything else. So it's a crazy thing. All that has to be written down and determined. That is something we have to work towards in our society. All right. Now, next 3-4 slides are about the situation in India. To put it in one word, it is chaotic. We do not have a law like we have in the West. The country it only has a draft law which has not been passed yet. And there are some organizations, there's an organization called Vriddhi Center for something. AIMS has brought out a nice paper, which says that even when there is no law, this is what I liked about this paper. It is our ethical duty as doctors, not just legal, to do the right thing by the patient. And this is where we as doctors are failing in this country. Take it from me. Because we are so scared about medical legal things. We never advise the patient about palliation. So you put everybody, as Ravi was saying sometime, go take everybody to the ICU, put them on ventilators, inotropes, and this and that when they have terminal disease, metastatic disease, which is not treated. Why? Because you're scared that somebody in the family may go to court against you. All right. And that is not the way to approach. Even though there is no law, it is our ethical duty to educate our people. And these are the 4 steps they recommend. It is basically a summary of what we have been talking about for the last 1 hour. To understand and recognize futile treatment. Don't keep on giving chemotherapy and radiotherapy and this and that when you know it is not working. Take the caregivers into confidence. Consensus is important. Have an end-of-life pathway, something like the Liverpool pathway. As I said, But have a, it is a combination of the things that I mentioned. DNR, no nutritional support perhaps, only hydration, no antibiotics unless the patient wants it, good sedation, good step ladder pain. These are the 4 or 5 basic things of a pathway. Have it written down in the institution and follow that. And remember, symptomatic treatment only. Stop your radiotherapies and chemotherapies and various other medications that you may give. Only treat the symptoms. Now, this is a very crowded slide, but this is a lovely, lovely paper by Bhatnagar in Indian Journal of Medical Research, which tells you the challenges that we have in India. It really is a tremendously well drawn up graphic. And I really, when I was preparing for this talk, I came across this paper and I was really very impressed with it. There are 3 main headings for your challenges. These are the patient selection. Okay, who is the kind of patient where you would really recommend palliative treatment, difficulties in communication, and above all in this country, because we don't have laws, a legal dilemma. I won't go into each of these because it's going to take a long time. I'll touch upon certain important things. Now, there is lack of clarity about disease-specific criteria where you can say all of us can come to a consensus about palliation. It isn't there. It's a gray area. That is one big problem. We somehow feel, as I said, do not talk about death. It's a wrong, bad omen. So we never accept it. And so we have this desperate desire of hope. And people say, if you have 1% chance, go and do a laparotomy for a patient with ischemic bowel, because it becomes ischemic because of inotropes from septic shock, from metastatic disease and a perforated cancer. Okay, disseminated perforated cancer, septicemia, strong inotropes, rest of the bowel is necrotic. Do a laparotomy. Completely meaningless. But there's a desperate hope that if you do something, that may happen. Communication is a big issue. We do not somehow manage to communicate with our people. Lack of advanced directives. If somebody wrote something down, then it would empower the doctor to say, look, this person doesn't want resuscitation, so we are not doing it. It's a DNR. He doesn't want ventilation. Because many times when I find that when I communicate with, suppose a person has 3 sons or 3 children, the person who comes there, tell him, that ventilation is futile. He'll say, okay, doctor, do what you want. But the sister or the brother comes, whom you would never have seen previously, and says, no, do everything. He's our only father. Do everything that you have to. This conflict would not be there if somebody wrote an advanced directive. Okay, again, the patient selection. We have no awareness. That is the main thing. Forget about awareness among patients. We have no awareness among medical personnel. I don't mean only doctors. I mean the whole healthcare system. This is something we are up against in this country. Okay, and we have to know what to document for proper communication. As you say, you have not communicated properly if you have not documented what you have communicated. It's a very important thing. So you have to document everything. And when you are talking about communication, when you document it, what is there to document? What is the legal requirement? That is something that we do not know. And lack of uniformity in everything across the country. If we had a law, that would have solved many problems. But at the moment, we don't have a law. We are only going by the Supreme Court judgment, and that again is open to interpretation. So it is a little complex in this country. But I go back to the beautiful statement made by the Ames paper that beyond law, all of us as doctors have an ethical duty to serve the patient. This is a complex graphic. I put it up because it is a summary of everything that we have said so far. I won't dilate on it. First, make sure that apart from you, the treating physician, there is one more physician who agrees with you that the patient is ready for palliation. It's important. Get another opinion. There must be consensus between the 2 of you. Once that consensus comes, get a consensus among the family. If you do not get a consensus, do not institute palliative care. Once you get a consensus from your colleague and from the family, get an end-of-life pathway. We have mentioned about the components of that pathway. And then stick on to only supportive care and document everything. When you do that, you will be satisfying yourself with both the ethical, moral, and the legal components of patient care. That is the important thing. So get this consensus and document it. Now, the situation in India, as I said, because of the lack of a law, is still uncertain, but one needn't worry too much about it. There is a draft bill which is yet to be passed. This was a famous case in Bombay, Aruna Shanbag, who was in a vegetative state for many years, and Supreme Court at that time allowed that the support can be withdrawn, but they had put up so many rules that it was practically impossible to follow. They had said that there must be 2 medical teams which would approach a high court to permit them to withdraw care in similar cases in future, but that was unworkable. So it has now been recently modified by the Supreme Court itself, where you do not have to go to the court, but you can have a medical board that goes to the district collector, a medical board in a hospital who goes to the district collector, and who would then form another medical board consisting of government doctors, because they don't want to trust the private hospital doctors very much. So they would form a second board of government hospital doctors who would come and see the patient in a private hospital and then certify that the ventilator can be withdrawn and the supportive care can be withdrawn, because the patient is in a permanent vegetative state. If that is done, then you can withdraw the care. Okay, but what is the future for us? I think what we have to do is increase awareness. It's not an easy thing. All of us as doctors must understand futility of care, understand the philosophy of palliative care, and I hope this discussion today has added to some extent in that direction. Communication and documentation, I have mentioned this 1,000,000 times in this hour of my talk. Encourage advanced directives. Today, the advanced directives, for it to be valid, is very easy. It just needs 2 witnesses and 1 notary. You don't have to go to the government, you don't have to go to the courts. It's like a will. Get your thing signed by 2 witnesses and a notary. And all this must be done when you're well. Do not wait until you're unwell to get an advance directive. As I said, I've already written my advance directive. Remember that this is a sensitive social, cultural, and emotional issue, well beyond the physical disease, well beyond that. And so we must be sensitive to that and do not push. You can always suggest, sit with them, spend time, get 1 or 2 people to be with you, have a board meeting, or instead of a one-to-one, have a few people amongst yourself, among the doctors and the nurses, have some from the family and the patient, have a consensus building exercise. But if you feel that you're not winning, don't push, because you can then end up in legal trouble. Don't push your methods and don't push your points of view. If they want something done, even if it is illogical, you're duty bound to do it. That is something which you have to understand. All right. Thank you very much. And thank you for your patient listening. And I would really appreciate comments from the youngsters. I know that Ravi and Ramakrishna have given excellent inputs, but I would be happy if I find youngsters talking about it. Go on. Raise your hands and give your comments.
I think this forum gives you the opportunity to give your comments from the comfort of your own home without being seen. And so you should be bold. You should also learn the ability to talk. Please.
You must develop this habit of talking. Nothing is silly and you should not hesitate to talk. It's very important. Nikita, go on.
Sir, if, for example, I'm treating a patient with a palliative care and suddenly they wanted to back off, I can just stop it, or
Back
they
off in
want
what sense?
They want to move ahead with the treatment part, sir.
Yes, you have to do that. Yeah.
Yes.
Yeah. If you do not have the concurrence for palliative care, even though you have started it, they have changed their mind. They have a right to change their mind.
And if they change their mind towards euthanasia,
Yeah.
what is my role, sir? Am I
Not allowed. It is illegal and immoral in this country as of now.
okay, sir.
Euthanasia is something which is practiced in very, very small parts of the world, and it's not accepted now at all.
Okay.
It's a subject of another talk. I can give you another talk on it some other time. Yeah, but it's not done in India.
So I can just say that
that you won't be a part of it.
Yes, sir. Okay.
Yeah. What did you learn from today's talk, Nikita? Did you learn anything, or did you know all this yourself beforehand?
No, sir. I learned a lot of things, sir.
Yeah.
But it's it's very difficult to put in words, sir.
Yes.
It just makes clear that what to consider and how to consider.
Right. Pavan, what did you learn today?
Sir, palliative care is not only the terminal care, but also it involves a lot of social and emotional support from our side, from the patients and attenders side.
Yeah. Okay. Sanya, are you there? Are you in a place where you can talk?
Sanya?
Maybe she's logged out. Yeah. Okay. Indraja, what did you learn?
Sir, actually, this is a very difficult to practice, sir.
Mhm.
But we should learn how to practice this.
Yeah.
And we have to respect the patient, what patient wants.
Okay.
Yes.
All right. Ramkrishna, your closing comments?
Yes, sir. It was a very nice and illuminative. Almost everything is covered, sir. Only thing, the pain part, I think it was not the subject. You didn't touch upon that.
Yeah.
What else? The other thing, I put a comment there with respect to antibiotics and ventilation. What is that? Ventilation. Those things you were discussing.
Yeah.
At that point of time, I put that because if antibiotics and this ventilation, something else you have to nutrition, yeah. If
purpose is to prolong life, no. If it relieves symptoms, yes. Yeah.
If it is the purpose is to prolong life, you should not give.
Yeah.
If it is the purpose is to improve his symptoms and cure, sometimes patient may be having one temporary infection. So if you give that, his pain may be relieved.
Yeah.
So in such case, we must give.
Yeah.
That is the purpose.
All right. Ravi, your closing comments.
The extremely, very wide ranging and a very relevant talk. I think you have touched upon so many important aspects. I think it is an amazing, I think this talk should be published elsewhere because it is so good. Thank you very much, sir. I think the important thing is during the palliative care, as you said, apart from all the principles, where if you are the person under whom the patient is, the patient should feel you are their advocate and you are there for them, and you should be empathetic and listen to them, and then give them the sort of the advantage or the advantage of your experience and how you have dealt with, giving them some anecdotal reports and the anecdotal experiences so that they can understand, and they should be made to feel that they are not doing anything wrong by backing off in terms of the treatment, because the guilt of not doing anything is there amongst most of them. So you should reassure them that by not doing anything is also an option. Yeah. So I think that is the important thing. I think empathy and being very careful, as you said, you should not push any of your views, because that may be construed as something difficult or legally you may come to have a difficulty later. Thank you very much, sir.
Okay. Nikita, you have your hand up again. Final comment or final question?
The exact word palliative, what does that mean, sir?
I don't think there's a single word meaning.
Cloak, sir.
Cloak.
Palliative means cloak. When you cannot treat a symptom, just cover it.
Okay,
That is the meaning of
good. My learning of the
palliative.
day. Yeah.
Yeah,
Okay.
yeah.
Yes,
That's good.
and another thing I want to clarify, I think one of the student got confused. See, palliative care and primary care, they are not mutually exclusive. Both
Yeah.
can go hand in hand.
Yes,
If
yes.
the patient wants primary care, he can continue. Along with that, we can give
Palliative.
palliative
Yeah,
care.
that
It
was,
doesn't mean that we should stop the primary care.
yeah, absolutely. Yeah, yeah. Okay, thank you very much.
Thank you.
I'll
Thank you,
close
sir.
the meeting now. Good night.
Yeah, thank you. Good night, sir.
Thank you, sir.
Good night.